Hello, my name is Paulus Kirchhof and I'm joined by Atul Verma. We are here in New Orleans for the 2025 AHA scientific sessions, and we're going to talk about the results of the OCEAN trial, one of the trials that was presented here in a late-breaking clinical science session. So, Atul, why did you start OCEAN? What was the motivation to do the trial?
Well, Paulus, as you probably know, after we complete an AF ablation on a patient and they're doing well, one of their first questions to us always is, can I stop my blood thinner? And I just kept hearing this question over and over and over again. And so we decided, you know what? We should test the hypothesis and get an answer for the patients.
Were there reasons to believe that the stroke risk is different after AF ablation than in other patients with AF, where we continue lifelong anticoagulation, right?
Yeah, exactly. Well, I think this was really an unknown because, as you know, we measure stroke risk for our atrial fibrillation patients based on a CHA2DS2-VASc score, which are clinical risk factors. There's nothing in that score about the duration of atrial fibrillation. So we really didn't know whether the duration of atrial fibrillation affects stroke risk or not.
So how did you design the trial?
Well, we decided that we were going to do a randomized study of continuing oral anticoagulation, which in this case was rivaroxaban, versus aspirin as the other comparator arm. Some people say we could have used placebo instead of aspirin. However, keep in mind this was 10 years ago, prior to a lot of the guideline changes, and aspirin may offer some benefit in higher risk patients. So we took patients who were at least 1 year after a successful AF ablation. We did minimal monitoring to ensure that they had no atrial fibrillation recurrences, so 2 Holters within the first 12 months, another 48-hour Holter prior to enrollment. If they had no atrial fibrillation greater than 30 seconds, then they could be entered into the trial. All patients received a baseline cerebral MRI, and then they also had another cerebral MRI at 3 years. And so our composite outcome for this study was stroke, systemic embolism, or what we called covert embolic stroke on MRI. And these are not the small little strokes you see after ablation. These are large strokes that are greater than 15 millimeters.
Okay. Wow, so you had a combined clinical and imaging outcome for the brain lesions.
That's right.
Yeah. So what you're describing is what we would now call a low AF burden population. And were there any clinical features that the patient needed to have in order to be enrolled?
Yeah, so all of the patients needed to have a CHA2DS2-VASc score of at least 1, or if they were female or had vascular disease, we mandated that their risk score had to be 2 or more, given that those risk factors may not be equivalent in terms of stroke risk to some of the others.
Okay. So these are all patients who would have an indication for anticoagulation based on current guidelines.
Exactly.
So tell me, how many patients did you enroll? What were the clinical characteristics?
Well, we had hoped to enroll 1,572 patients. However, after 1,284 patients, the DSMB asked us to stop enrolling because of a high likelihood that we would not demonstrate any benefit of oral anticoagulation. Now, none of the investigators were actually informed of this, and all of the patients continued their 3-year follow-up in their assigned therapy. So the rest of the trial was really unchanged. And, well, the results were quite surprising.
So what was the age and the CHA2DS2-VASc score and the clinical features of the patients?
These were very typical atrial fibrillation ablation patients. So on average, they were about 67 years old. About 2/3 of the patients were male. The average CHA2DS2-VASc score was 2.2, and more than 30% of the patients had a CHA2DS2-VASc score of 3 or more. So we had a pretty good representation of the different CHA2DS2-VASc scores. And overall, the ejection fractions, left atrial sizes were fairly normal, typical for an AF ablation type population.
Okay, wow. So, what did you find?
Well, we found that our event rate, our composite of stroke, systemic embolism, and covert embolic stroke, was far lower than what we thought were fairly conservative predictions. So in fact, the annualized risk of our primary composite outcome in the anticoagulation arm was only 0.3%, and in the aspirin arm, it was only 0.6%. This was not statistically significantly different, and these rates are far below the 1% per year threshold that we normally consider as an indication for anticoagulation for atrial fibrillation.
Wow, that must have been a big surprise when you first heard about it.
It was. We knew that the event rates were going to be low. We didn't realize that the event rates were going to be this low.
So, give me the numbers, Atul. So there were about 600 patients in each arm, followed up for 3 years. How many strokes and how many covert strokes and systemic emboli did you observe?
Yeah, so the number in the anticoagulation arm was only 5.
Okay.
And in the aspirin arm was only 9. So hence the very, very low percentage of risks. We thought covert embolic stroke was actually going to enrich our endpoint and save on sample size. There were only 2 covert embolic strokes in the entire trial. Only those 2 occurred in the aspirin arm. And if we look at any stroke of any size, greater than or less than 15 millimeters, 96% of the patients in the trial had no new stroke detected on their MRI between baseline and 3 years.
Wow. So, I mean, you've been following that field quite intensively. What's the consequence now? What should we do?
Well, good question. So I think, first of all, our guidelines say that these patients should continue oral anticoagulation for life. I think now with OCEAN, and there's been another trial, Alone AF, I think we can safely say that for these patients with a CHA2DS2-VASc score of 1 to 3, perhaps even 4, we may be able to discontinue oral anticoagulation. I think for very, very high-risk patients, CHA2DS2-VASc above 4, we still can't answer that question with our data. So those patients probably should continue oral anticoagulation lifelong until we have further data. But you know, Paulus, this is very consistent with some of the data that you published earlier and Jeff Healy published with subclinical AF, right? You showed that when you have lower burdens of atrial fibrillation, you have lower risks of stroke.
Yeah, and that's potentially one of the new emerging concepts, that the burden of atrial fibrillation is a modifier of stroke risk. So, Atul, most patients who undergo atrial fibrillation ablation do not have a recurrence in the first year. But when you follow them up for longer, they do have recurrences more often. So
Yes.
have you got any concepts on what to do when you stop anticoagulation and then 3 years later that same patient comes back and
Yeah, it's a very
has
good
recurrence?
question. So during follow-up, 5.5% of the patients actually needed a repeat atrial fibrillation ablation procedure. This was also much lower than we thought it was going to be. So it seems like the success rates in this carefully selected population were actually quite durable. But I think at the same time we had specified rules that if a patient needed, for example, a cardioversion, you could restart oral anticoagulation for a short period of time, do the cardioversion, continue it for a short period of time, and then stop it afterwards. This was actually protocol mandated, and we didn't see any increased risk of events in this patient population.
Wow, so congratulations to completing a really important and thought-provoking trial, and we look forward to see how this is going to influence clinical practice.
Thank you very much, Paulus.
Thank you, Atul.